sick and tired of the high costs and inefficiency plaguing our U.S. healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
Welcome to Broken Healthcare. My name is Ray Kober, and I am your host. I am joined today by none other than Dan Marino.
I've only heard that a few times.
You never heard that before, have you, Doug?
Never, man. Every conference, I'm a Pittsburgher, where I grew up, and I've been hearing this literally since I was, 15 years old. So yes, not the first time.
Dude, when I first saw you, and I saw you, so Doug and I travel kind of in the same circles. So we run into each other at all these educational conferences on healthcare and how to get better at this game so that we could bring the best in the business back to our clients and their internal clients by osmosis. And I must have seen you, I don't know, a half a dozen times. And I was like, if that guy doesn't look like them, and I'm a Jets fan, Doug, so this is like PTSD for me. Every time I see you, I'd be like, ah. and then we finally met, and you were awesome. You had a interesting story too. Like someone ran into you in a supermarket that was actually a relative of Dan's.
That's his mother-in-law. So I worked at a Jewish grocery store when I was growing up in Mount Lebanon, Pennsylvania, and his mother-in-law lived right across the street. She shopped at our grocery store every Saturday, and I swear to God, probably every 2 or 3 times, she'd walk by me and she'd do one of these double takes. She's like, "Oh my God, you look so much like my Danny." So yes, I have been hearing this for 35 years now.
Well, that is a compliment. Dan Marino, I mean, I hate to admit it, but one of the best quarterbacks of all time, handsome devil. You could have a worse doppelganger.
Agreed. And he went to Central Catholic in Pittsburgh, so a shout out to Central Catholic. And because when he went to Miami, I became a Dolphins fan.
Oh, wow.
And actually was a Dolphins fan for probably 15, 20 years. And hands down, one of the best quarterbacks that never got a ring. It's a shame.
I know. Well, what are you going to do? It shows you how tough and competitive it is. You could be elite. You could be at the top of your game. It really, at the end of the day, it's a team effort, though, right? No one player can put everyone, right?
It's no different than in the operating room. If you walk into that operating room and you don't know what your team looks like, you have no clue as a surgeon how that outcome is going to play out. That's why the team is so important.
Great segue. So speaking of that, what exactly, our audience is pretty diverse, I should say. So we have people that are in the business realm that are trying to figure out how to best do healthcare for their organizations. We have people in our circles, brokers and consultants that are looking to up their game. And we have everyday people that, maybe were victimized by the healthcare system. Maybe they had a negative experience or a run-in and they're looking for answers. As you know, there's over 100 million people in the U.S. that are in medical debt. And so this is really kind of a hot button topic, and it's kind of the thrust behind the podcast. But so I guess if we just met one another and, we exchanged pleasantries and introductions, what do you do?
I've been asking my question that my entire life. So I live squarely in the middle of the self-funded healthcare marketplace. So what does that mean? These are the employers that have determined it's best to build direct relationships up and bypass some of the commercial carriers and buy healthcare directly. And so I came out of the provider side. So most of my clients, most of my friends live in the provider side, and I identify the highest performing providers that know how to deliver better health outcomes for a lower, transparent, known, and many times bundled price. So what does that mean? So if you think of a surgery, there's 4 components to a surgery: facility surgeon, anesthesia, and implant. We bring all that together under one price, one episode of care, and deliver that directly to the employer or actually their workforce. And we improve quality outcomes. So the patient gets a better health outcome. the employer is saving a ton of money, and many times the patient is now can afford healthcare. And then the providers, the folks that I work with closely, they are going to eliminate some of the friction that comes with healthcare. We always hear about physician burnout, and a lot of that is they spend more time billing, coding, collecting, and going through the appeals process with these carriers that they don't want to do. So this is a term that I like to use is disintermediation, allowing the two parties that need to come together directly and eliminating a lot of the middlemen in between. So that's the core of the business. And then, Ray, I think you and I spent some time talking about a new division that we launched called High Performance Navigation. High Performance Navigation works with benefit advisors such as yourself to properly install a direct contracting strategy. So on one side of the house, we're going out and we're building these direct contracts. We've written thousands of these across all 50 states across the United States. And then now we have to install it properly into the plan design to drive utilization, because it does require some level of navigation. So we wrote a book, and we'll put that up later on for everybody, called The Power of Navigation. And it's really a playbook that allows a benefit advisor or an employer to understand what is involved in properly installing a direct contracting strategy so they could take advantage of the great cost containment that comes with it.
Doug, one of the issues that I kind of run into time and time again in the educational process is either I come across a CFO or a business leader that is fully insured, or they may be self-funded, but they're self-funded without any real cost containment built in to the mix. So they're in an ASO arrangement, administrative services only arrangement, which essentially means that the insurance carrier is controlling everything, if not most everything, in the plan. And so I think a big hurdle that a lot of the CFOs have to get over when I meet with them and just have this frank discussion with them that, and I hate to be blunt, but you're doing it wrong, right? So just if you would, in terms of getting to where you are, right, and these contract negotiations with providers, I think first the first hurdle is this possible? Like, can I actually control the cost of healthcare? Right. That's kind of baby step A that they have to take. And then if the answer to that question is yes, then give us an idea of, how much money can be saved deploying a strategy like yours.
So I want to start with something you touched on and add a little bit more depth to it. So when you look at the plan construct, we're not able to affect anything in a purely a fully insured plan. The incentives aren't aligned there. The health plan itself has no incentive to lower the cost of healthcare because they work on something what's called MLR, medical loss ratio, which means the more they spend, the more they make. That's why healthcare costs go up year over year, because it's in the best interest of that the commercial carrier. When you move into an ASO, it's almost like lipstick on the pig. It makes the employer feel like they're doing a little bit more because they are self-funded, but many times the commercial carrier controls all of the levers in that ASO. So again, they're just not financially incentivized to bring cost containment to it. You can, at that point, start bringing in basically carve-outs to that ASO plan. And some of those carve-outs would be to install a direct contracting strategy. It's challenging with some of the carriers, a little bit easier with other carriers. Where you get more traction is when you truly move to a independently owned third-party administrator, where their alignment is more in alignment with the health plan itself. Because then you could start like building blocks, changing out the components of the health plan to allow for direct contracting to happen. So I will say that the work that we do in the direct contracting world will hands down bring the largest cost containment to a health plan. But it is a little bit more work than just, say, replacing one of the top, the big three PBMs, which is the first step that most take and should take. But after you find that cost containment in the PBM, when you move to a direct contracting strategy, you could typically find about 60 to 80% cost containment in your highest cost events. So this is not allergy appointments or your traditional just doctor one-on-one appointments where that appointment may cost $150. These are high cost steerable events. So think knee and hip replacement, spine surgery, cardio events, bariatric surgery, even your most basic surgeries like a gallbladder removal or a hernia repair. You're able to bring 60 to 80% cost containment to those events, which is
these are the big ticket items that you're describing, right? So I think any business leader that's looking to get a handle on this has to understand what the breakdown is, right? Where are my dollars going? And 80% of their dollars, 80 to 85%, are paid claims, right? And when we look at, what you just said, just to piggyback off of that, it's not your wellness exam, your scheduled visit with your doctor, the routine type of stuff. That's not the huge cost driver. It's where the real money is in the scheduled surgeries. Pharma, as you said, is the low-hanging fruit, and that's typically a very easy lever to pull on. And, even in some ASO arrangements, we could pull on that lever and trigger, 30 to 60% savings on just the pharma vertical. But now when you start talking about surgeries within, a fully insured plan or within a plan that has the insurance carrier handling administration, what's the variation that you see for, you said a knee surgery, for example? What's the spread that you've seen out there for something like that?
So we'll stick to the most common one that people use is a knee replacement surgery, just because it's very common and it's costly. So in a traditional PPO network, which a lot of self-funded plans use, that member is going to be going to the hospital for that knee replacement. And the plan's going to probably be paying somewhere in the area of about $70,000 to $80,000. Now, I have seen knee replacements go as high as $200,000, $220,000, but 70 to 80 is the mean. Now, when we move that case to a surgery center, several things happen. First, you're bringing the cost containment to it. And we'll come back to the 4 components here in a bit. But the most important, you're also improving the quality outcome of that surgery. So we'll touch on that first. So to start off, we were talking about Dan Marino and the quarterback and why he was not able to win that Super Bowl, which was his front line. Let's continue that analogy when that surgeon walks into the operating room, or the theater that we call it sometimes. If that surgeon walks into the operating room of a hospital, that surgeon's dealing with a hospital managed, administered surgical team. So the anesthesiologist, the scrub tech, the rotating nurse that are in there are assigned by the hospital administrator. And sometimes those folks may be a per diem, they may be a traveler, and that surgeon more than likely has never operated with that team before. So the instrument handling gets a little bit wobbly because nobody knows what's going on. Now, in comparison or contrast, when that surgeon walks into the operating room of the surgery center, it's his or her operating team. It's their anesthesiologist, their scrub tech, their rotating nurse, and the efficiency of the instrument handling and just the overall operation. It's like a well-oiled machine, and they're done in less time. So it reduces the anesthesia, the time that member is under gas, which improves their recovery time because they don't have to burn that off. And at the same time, it eliminates a lot of medical errors. And because the surgery center of an ambulatory surgery center it's a cleaner environment. It's where healthy patients go to get an elective surgery, in contrast to a hospital, which is a little bit dirtier of an environment. So your complication rate increases, your infection rate increases, and the member just gets a lower health outcome. So it's a win-win on both sides.
And there's also a concept called bundled pricing, right? And so the patient in this case is basically getting full and complete transparency. They know prospectively before the surgery occurs what their bill charges are going to be. Is that what a patient in, any XYZ health plan can anticipate as well?
Yeah, so I'll dive a little bit deeper on a bundle. So a bundle, it's a fancy word for an episode of care and everything that lives within that episode of care from a billing finance standpoint. So to break it down a little bit more, there are 4 components to a surgery, and sometimes there's more, but you have the facility where the procedure is being done, the surgeon or the professional fee, the one that's doing the cutting, the anesthesiologist that's putting the member to sleep, and then the implants, which are what may go inside of that surgery. So in this case, a knee. So there's a knee implant that needs to get put in there. And then inside of the bundle, you're going to have some pre-op work, some post-op, check the wound site, and sometimes some physical therapy if that's part of the bundle. Here's where the cost containment comes. That facility fee makes up about 75 to 80% of that total cost of the episode of care. And so that's the hospital. It's a more expensive place of doing care. So when you move a case from a hospital to a surgery center, that's the lever that we're pulling to affect the cost containment that the employer is going to see, because it's just less expensive to do a case in a surgery center. And that one lever is the one that brings that 60 to 80% cost containment. And a lot of times what we do is we'll shift a little bit over to the surgeon to pay them a higher rate, because what we want from that surgeon is a 30-day or a 60-day warranty, which is basically a guarantee that the work product that they are going to deliver is going to be in the best interest of that patient, and almost like a you break it, you fix it model, where, hey, anything that happens in the upcoming 30 days, if it was due to your poor work product, you need to go fix that. And so what that does is it incentivizes, motivates that surgeon to be their best. And frankly, what happens, Ray, is we will have practices that may have 10, 15, 20 surgeons in the practice. They're narrowing those that are doing a bundle down to their highest performing surgeons, because that practice is now at risk for a high quality outcome. So the member gets the best surgeon there and they get a guaranteed outcome. And from a member perspective, when we reduce the cost of the surgery, the employer will waive that member's copay, deductible, and coinsurance, now making healthcare affordable, because a lot of these folks can't afford healthcare when they have a $6,000, an $8,000, a $12,000 max out of pocket, a MOOP, whatever you want to call that. Now the member can afford it and not put off or delay that knee surgery that they've been needing for a couple of years.
Amazing. So I don't know if I told you, but I'm one of the producers on It's Not Personal, It's Just Healthcare. And that's a documentary that's going to be coming out. And it features Dr. Keith Smith from Surgery Center of Oklahoma. And he started this back in the 1990s just because he was frustrated with being a physician and having to deal with the system that was making it increasingly more difficult for him, as well as eating away at his compensation and ultimately deteriorating the care of those that he was treating. And so when you hear his story and he talks about the fact that going independent meant so much of, cutting out of the bloat and the excess, that his surgery center now regularly charges, it's not uncommon for them to be 1/10 of the cost of a traditional surgery in a hospital setting. And it's just mind-boggling, right? But if you think about it, we shop for everything in our lives. My sister-in-law's car broke down the other day. So I had to go out there and give her a hand, pull out the jumper cables, all that stuff. Figured it out. It looked like she needed batteries, right? So her car, there was like a malfunction with her start mechanism. So we took it to the local repair shop. And while we were there, I asked him, what's the price? And he was able to call ahead. It was a battery that needed to be replaced and an auxiliary battery that needed to be replaced. And, it was like $400 plus $40 labor. And it's a regular mechanic that we use. So we trust them. They're not price gouging us. But the point is, we knew before the repair what the cost was going to be, right? Yeah. It's just common sense. We do it every day. Why do we not do this with healthcare, Doug?
Imagine if you had to put that on your insurance card, what that would do to the cost, because now the mechanic is going to have to send a bill to insurance to get paid what he wants to get paid. The insurance company is going to deny, he's going to appeal, they're going to drag it out, and it's going to take 60 to 90 days for the mechanic to get paid. So he's carrying that cost. And what ends up happening, and these are real numbers, Ray, real numbers. In healthcare, the cost to administer all that, on average, according to the MGMA, the HFMA, all these acronyms of groups of healthcare administrators, 29% to administer what he could have received up front. It just doesn't make any sense at all.
No, it's crazy. I actually looked up the charge master for NYU, and I looked up several hospitals. NYU was one that you could actually, to their credit, you could actually see their prices. Sometimes it's just, like you have to be a computer engineer to download whatever it is that they put out there and, work some kind of black magic to get numbers. Yep. But even NYU, for a hip replacement, I think I looked up, the range in prices on the charge master range from somewhere, from what I recall, a little over 26,000 to over 260,000 for the same exact code, the same exact surgery.
Depends on who's buying it.
It's crazy, right? What would you say?
It depends on who's buying it. So let's spend a few minutes on charge master. I love this conversation. Awesome. So if you look at the back of any hotel room, they have their charge master. They actually call it their rack rate. And then it just makes people feel better because they got the room for less than what the rack rate is. So in healthcare, there's a charge master that sets the price, because what happens, the perverse incentives, these carriers walk in, they say, I need a bigger discount than you gave me last year. And so the hospital or the practice needs to go, well, what was that number last year? And they say, well, you give us 40% off of billed charges, which is the charge master. And we need 45% this year. And so when they give that discount, it is off of the charge master rates, and every purchaser has a different basis off of the top charge master, rather than in every other industry that we've worked in, it's off of cost of goods sold, and it's a markup above that. So we need to earn 10% above what our costs were, 15% above what our costs are. So I'm going to tell you a funny story. I was sitting, and I'm going to protect the innocent, the guilty, whichever bucket you want to place them in. I was sitting in a hospital CEO's office once, and in comes a carrier rep, one of the carrier leaders, and I'll not protect, I will not share the name. And he said, Mr. CEO, I need a deeper discount this year. My competitive carrier down the street is kicking my butt, and we are losing market share because I am not getting enough of a discount. And they went back and forth negotiating, and he said, okay, I'll give you 5% more. The carrier rep walked out celebrating, I got 5% more. And I watched the CEO of this hospital spin around to his CFO, and he said, do me a favor, take that charge master, mark it up 7% so we could give that clown his 5%. And that was the day that I walked out of there, and I went, oh my God, this is how healthcare works.
That's insane.
Scary, right? It is scary.
Yeah, because you could take any discount you want as long as I get this, as long as I get to choose the starting price. Right? It's like, no worries. How much of a discount do you want? We'll just make it higher. But it boggles the mind. But I think executives generally are not in the know about this, first of all. The frustrating thing, though, for me is having conversations with so many who are in disbelief because their brokers don't have these conversations with them. The brokers typically are laser focused on spreadsheeting a variety of health insurance carriers come time for open enrollment and helping their clients choose the lesser of, the two evils. It's a recipe for certainly not maximizing this expense bucket, right? It's just no way to manage costs. Do you think we'll ever get to a place, Doug, where we have price transparency? Do you think we'll see the charge master disappear one day?
I don't know. Everybody is manipulating price transparency today. It was a good start to start the conversation. There's a lot of groups out there that are extracting the transparent price of these systems, but it's still flawed data. So going back to my 4 buckets of what lives in a surgery, a lot of these price transparency websites are only listing the facility fee from the hospital, because that hospital operates in what we call corporate practice of medicine state, where the doctors are not employed by the hospital. So the only number that's being presented is the hospital fees, which will include the facility and many times the implant fees. But professional fees, which is the surgeon and the anesthesiologist, are not included in that. And so we're still not truly comparing apples to apples. Again, it is a great step forward. I think we're heading in the right direction. I still think we have a ways to go.
Oh, for sure. And so when you have an independent TPA and we have a custom plan, we've broken away from the insurance carrier altogether. And now we have a high performance network. We have you plugged in. Are you interfacing with the plan via the TPA? How is that kind of bolt on happening?
Yeah.
And I don't want to get too deep into the weeds, but I just want to understand. And then for the member, what is the member experience like as compared to what they're used to in a fully insured plan?
Yeah. So this is a term that we call care navigation. And just like transparency, it is defined and differently based upon what is being delivered. So a status quo navigation firm is typically just looking at the existing, what's in network, and they're talking to the member saying, where do you live? And they're doing a circumference and they're saying, here's 3 providers that are in that area. And they're really just glorified appointment setters. The next notch up starts looking at some quality measures, and there's quality measures out there, and I don't want to go into a rabbit hole and talk about the difference of the quality measures, because some are looking at data that's CMS related, which is really a Medicare, Medicaid population and doesn't look anything like an employer health population. So they start looking at quality measures. Where the magic really comes together is when the benefit advisor installs this plan amendment, this new benefit to the plan that allows for real care navigation. So what does that mean? They have the ability to call a nurse navigator and say, hey, here's what's going on. I need your help finding a provider that's going to deliver better health care, better health outcome, and allow me to take advantage of my zero out-of-pocket benefit. I don't want to have to pay and tap into my out-of-pocket. And so what this nurse navigator is going to do is access the platforms and the systems that we have been working with for years to say, hey, if you go down the street here, we could get you this MRI done for $400 rather than you going down the hall of the hospital and paying $4,000, which, by the way, your out-of-pocket's going to be $800. So make a better decision, go across the street, keep the $800, put that in your pocket, and you're going to get this done. And now your employer is going to save $3,200 once you factor that in. And what does that mean? They're going to be able to enhance and enrich your benefits in another place next year, or potentially even give you a premium holiday, which means that you're not going to have to pay your premiums one year just because the health plan has saved so much money. So it just really gets all of the incentives aligned. The member feels so much better because they now have a clinical nurse many times helping them navigate healthcare, which they're not used to. So it's almost like having your own personal concierge to help you out. So it's a great benefit that way.
Yeah. And so I think a lot of people get hung up on, change is always very difficult, right? There's a famous Peter Drucker quote, culture eats strategy for breakfast. And on one of my podcasts, I basically rant on that a little bit. And I'm like, you know what? I get where that's coming from. Everybody quotes this like ad nauseum. But the reality is, this is one of your biggest expenses as an employer, typically after payroll. It's usually top 1, 2, or 3. And if you don't have any strategy, you can't have culture. If you don't have strategy, you have no business, you have no business, you have no people, you have no people, you have no culture, right? So
simple thing.
It's like, hey, man, if you now start measuring this and you now have a mechanism to manage it, why wouldn't you? And particularly when it's not all about dollars and cents, right? I think the real money is in the quality of care being elevated and quality outcomes. And often, if you look up Surgery Center of Oklahoma and you go to their website, they have a list of procedures and what the bundled all-in cost is. And in many cases, you could fly across the country, go there, have surgery, be put up in a Four Seasons, limo transportation back and forth with a loved one, and you still come out ahead of the game. And these are exactly the types of facilities, I believe, correct me if I'm wrong, that you're contracting with.
Yeah, we only work with the highest performing folks out there. So we're currently on a journey right now. We've already identified the upper quartile. So those that are working in the upper 25 percentile, we're on a journey right now to get to the upper decile. So those in the upper 10%. So it's identifying the facility where they're being done, but it's not the facility that delivers the outcomes. The facility gives the theater to the surgeon. It's the surgeon that delivers the outcome. So I don't want to call it a surgeon center of excellence, but really that's what it is, because we have looked at the data, and I could take one of the highest performing surgeons and look at his or her outcomes across 2 or 3 hospitals, 2 or 3 surgery centers, and the outcomes vary wildly, totally different, because it's the team that's in that OR with that surgeon, because surgery is a team sport. It is not just the surgeon that's in there.
Yeah. And so as the patient and the patient is engaging with their health plan, they have guidance. Do they also have choice? Are they kind of given, okay, it's this or the highway? Or typically, are there multiple surgeons, multiple facilities that they can choose from?
So we always recommend bringing the benefit in as an out-of-network benefit. So the member could still go to their PPO and absolutely nothing changes. But they need to be prepared to pay their 20% out of pocket, and they need to know that they may get a surgeon of lesser quality. If they call their nurse navigator, that's when they take advantage of the zero out-of-pocket benefit with a list of pre-screened, pre-sourced, highly vetted surgeons. And many times what we encourage the navigation teams to do is to present the member 3 options. Here's surgeon A down the street, he's 20 miles away. Here's surgeon B, he's down the street 30 miles away. Or if you want to travel, here's surgeon C, that is hands down one of the best in the country, and you could travel there. It is 100% your choice. Let us know how you'd like to progress. And so the member still has choice. They're just narrowing, taking a look at going to any market in any industry, and there's going to be dozens and dozens of surgeons. They're awesome. Not all the same.
That's what I'm getting at. So you're not as the patient, as the member, as the employee, as their family member, you're not given it's not a gun to your head kind of a strategy, right? You always have choice. And if you're in a plan where there still is a PPO network and you choose to go down that path, you can certainly do that. Just know that it's going to cost your plan more money and it's going to cost you more money out of pocket. And your health outcomes are not guaranteed, because I often say, use like a Forrest Gump quote, surgeons are like a box of chocolates. You never know what you're going to get, right? If we're talking about a PPO network. But when you have guided, care management, you have a registered nurse as your quarterback that's guiding your care, that's looking at the data, that's looking at the options. I don't know about you, but I'd feel a lot more comfortable having a nurse team, nurse practitioner team, registered nurses, doctors who are familiar with the specific procedure that I'm going in for to kind of guide me and hold my hand and say, hey, here are some options that will work for you. They're phenomenal. Their quality is off the charts. And it's counterintuitive, Doug, but in healthcare, the highest quality is almost always the lowest cost. It's just the way it works.
Yeah, these guys do it all day long. And a lot of the providers that I work with, they get to the level of subspecialty. So when you go into an orthopedic practice, there are those that do nothing but knees, those that do nothing but hips, those that do nothing but shoulders, those that do nothing but ankles, those that are sports medicine, and they will guide the patient to the surgeon that is the subspecialist of that particular area, all the way down to those that are robotic and those that are non-robotic, because there's different ways to approach every type of procedure.
Yeah. So we could spend all day talking about this stuff. But let's kind of end it here, I think. I do want to know if it's a broker that wants to reach out to you, you're not client facing. So for those employers that are out there, I don't think you're going to be their go-to person. But what is the best way to learn more about your company and contact you?
So easily found on LinkedIn, Doug Geinzer, Geinzer. Email address is doug@providers.com. And Ray, I did put a link in there if you wanted to share that with your audience. There's a free download on an ebook that we wrote called The Power of Navigation. And this is a great book for any benefit advisor, any third-party administrator, any employer to read. And what it does is it lays out the entire playbook, the strategy on how to properly install a direct contracting strategy. Everything from the SPD, the summary plan description amendment, all the way through the care navigator, the different types of platforms, where you're going to benefit geography-wise, specialty-wise, plan design-wise. The entire playbook is in there. It's a free download. It's 40 pages, and it's a really quick and easy read. So if you want to share that link with your audience, that'd be the best place for them to go to learn this.
Awesome. Well, thank you so much, Doug. I mean, that sounds like a wealth of information. I'm sure you have 40 pages of jam-packed knowledge, and knowledge is power in this business. So I appreciate you sharing that with our audience. Thank you so much for joining us. And ladies and gentlemen, we'll see you on the next one.
Great. Thanks for having me.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show. One lucky listener every single week who posts a review on iTunes will win a chance in the grand prize drawing to win a $15,000 value private VIP day with Ray Kober himself. Be sure to head on over to brokenhealthcarepodcast.com and pick up a free copy of Ray's gift and join us on the next episode.